Yeah, that was actually from practice. According to her,
What is the next one here?
I thought I'd be I thought I
That makes sense.
Well,
I know, right? Really, yeah. I thought it was the adjustment from like 2 week, to like.
good for you. Good. Yeah, they got fun from the best here. That's what I heard. You have to work today. Yeah, good. Like I said, I had a problem. They come.
We no longer have this issue.
Absolutely.
Let's go ahead and get started. The word of the day for CME credit is Scripps, where Ron is from, Scripps Clinic. And hopefully we've got a good broadcast going. Drew and I and others were set, like most of those of the rest of you are trying to listen to these sessions from the outside. So hopefully we won't have any more technical failures and have good broadcasts throughout the rest of the year. So Ron Simon, who's a good friend and repeated visitor up here, kind enough to come up again. And interesting, this is a nice follow-on from the session we had last week, which was a surgical approach to chronic sinusitis. So today we've got a more medical approach, role of biofilms and chronic sinusitis. We may have some time for Q&A after, although we don't actually have a case. Ron's got to get on and even talk open Spokane a little bit later in the day. Thanks for coming.
Yeah, thanks, Bud. I'm happy to either ask questions during the presentation or afterwards, no problem. But before I get started, we were having an interesting discussion before we started this session. So last night I was actually showing some videos from my trip to watch the whales, the California gray whales, migrating down to Baja. They come right by San Diego and into Baja. And you go out in these little conga boats and actually touch and kiss and cavort with these whales. And you wonder, why in heaven's name do they make this annual trip? They have a 12-month gestation. Why do they make this annual trip from Alaska all the way down into the middle of Baja? And then when they're done, they just go back again and they just make this trip every single year. So it turns out that the bays that they congregate in to have their calves are 7 times the salt content of the ocean. And because whales are mammals, when this baby gets born under the water, if it doesn't get up to the surface in the fast enough amount of time, it'll suffocate. So that salt content increases the buoyancy. And then the flip side of that is because they also wind up impregnating males and impregnating females in the same day at the same time, and the gestation period is a year, so they travel all the way back to Alaska, come all the way back down again to have the baby. Well, it turns out, okay, these are mammals, right? They're not fish, they're mammals. So mammals have to actually have sexual intercourse as opposed to fish that sort of spew the sperm all over the water. So how are you going to have sexual intercourse when you're a 40-ton whale? So it turns out they do it in threesomes. And a male whale will get on its back, so it's belly up, and act like a bed. And the female gets on top of that male, and the third male comes on top of the female, they call it sandwich sex, and impregnates the female, and then they separate, and then the males switch when they find another female. So it's pretty amazing. I highly recommend the trip if anybody wants to do it, but it's about a 12-hour drive south of San Diego. Anyway, for years, as you know, we all, especially being an AERD, been very, very interested in chronic sinusitis, nasal polyps, and what to do about it. And when the biofilm story started to come out, it was obviously a great connection, and spent a lot of time trying to figure out how we can deal with that. So, give you some what I think are pretty novel ideas about this. Nothing necessarily that's yet particularly clinically relevant, but hopefully in the not too distant future. So, as we know, this is a really chronic disease, and it turns out that it's literally one of the most common problems that people have, affecting about 16% of the population. Incredible number, 13 billion physician visits a year. Because of the cost of surgery and medicine and downtime from work and all of that, more than $60 billion annually. And we always talk about this for allergic rhinitis. Now I'm beginning to think that it's just a field of sort of upper airway disease, if you will. They have a worse quality of life than most any other disease. We've always heard that about allergic rhinitis, a worse quality of life than asthma. And you wonder why that is. And I think it's because we deal so much with asthma control. And the goal of control is to have symptoms less than twice a week. What person with CRS, chronic allergic rhinitis, has symptoms less than twice a week? So they just have a horrible quality of life, pretty miserable folk. So what's the definition? It's kind of an arbitrary definition, kind of like urticaria, but it's really to have this persisting upper airway inflammation that persists for more than 3 months, despite treatment effects. And we all know the symptoms. People have a lot of postnasal drainage, although I like another one of my favorite diseases is laryngopharyngeal reflux, and that's these patients' most common complaint is postnasal drainage. And we know that our allergic rhinitis patients have postnasal drainage. I think the differentiating, maybe clinical pearl point is that most of the people who have allergic rhinitis will cough up their drainage, and if they can describe it, it's usually pretty clear, maybe a little bit opaque. It's not purulent or really mucopurulent. So these people should have purulent drainage, but the laryngopharyngeal reflux patients can't describe it. And to me, it's one of the most amazing phenomena because their complaint is 24/7, 365. They've got postnasal drainage, and they're just always clearing their throat. When you ask them what it looks like, they'll go, I don't know. And then say, well, you've had it, right, for years, all the time. What does it look like? They never really bring it up. So it's really more the perception of drainage as part of that globus sensation that people with LPR have. But these folks have the true drainage, and it's pretty thick colored stuff. Their nose is blocked up, and they have pain and tenderness, although pain isn't that huge a part of this. It's really more a sensation of pressure. Usually have diminished sense of smell. And they can get eustachian tube dysfunction and coughing and sore throat. But it's interesting that a lot of those complaints are really the laryngopharyngeal reflux complaints as well. But again, one of the big differences is, well, their sinus x-rays are abnormal, but also they can actually detect drainage. So can anybody name an FDA approved treatment for CRS? And it's not surprising because aren't it? There's literally not a single medication that's approved to treat chronic rhinosinusitis. And it's not because of lack of effort. I got into this space, if you will. I've learned in some business entrepreneurial terms in my quest to try to get some of this disease. You talk about the space that you're occupying. So in the CRS space, there's a lot of interest, there's things going around, but nothing seems to work. And venture capitalists are gun shy of investing in this space because nothing has really ever worked. But we do a lot for it. You probably can't see all the things on the list, but I really want to go over them because we try to do a lot for it. So people love to rinse and wash their sinuses. And you could do it with something as simple as saline. For a while, people were using hypertonic saline, and it sure gets a lot more stuff out. I don't know if in the end that's necessarily a good thing, especially living in a desert like I do. So people use the Neomed bottles, and we know about those. Years ago, Waterpik, the tooth cleaning device, had an adapter from Dr. Grosson, who's an ENT, You can put this adapter onto a water pick and literally flush and wash out your sinuses. That actually works pretty well for people that have had surgery and have fairly big apertures in their sinuses and have a lot of dry, thick secretions. And then maybe a newer device called NasoNeb, used to be SineNeb, now it's NasoNeb, and a much finer mist, kind of a nebulizer to get even medicine up into the sinuses, if not saline. So people put antibiotics in there, they'll put antifungals in there, you can put steroids in there, you can put combinations of things in there. There's a lot of people who are doing that. Typically antihistamines and decongestants are used for sinus, but I think that's because most of what's sinus are either migraine headaches or rhinitis or LPR. They're not going to do anything for the CRS that we're talking about. Intranasal steroid sprays, everybody uses them. I think they're helpful if your underlying disease is eosinophilic, if you have ARD, if you have allergies. But really, if there's infection and neutrophils, I'm not sure what that's going to do, but we all obviously use them. The problem is, how can they get to the mucosa if you're either full of mucus or full of biofilms? I think that really limits their usefulness. Conceivably, you can imagine how the 5-lipoxygenase pathway and all the pro-inflammatory mediators that are both going to generate eosinophils and monocytes and neutrophils could certainly be involved. So I think most patients at some point will try a leukotriene modifier. And as we all know, it does amazing things for some people, but not too much for most people. One of the mainstays is obviously antibiotics. And these patients get multiple courses of antibiotics, which only, I think, winds up supplying their biofilms with more ammunition. But we all try it. Lots of people will wind up getting injections of antibiotics. Again, putting antibiotics into the sinus rinses. Sometimes if somebody really has sinusitis, you have to be thinking about using something to cover anaerobes. So I think maybe the clinical pearl there is when somebody with, again, chronic sinusitis, I ask them to describe their drainage because I want to make sure they don't have LPR. I'll talk about this thick colored drainage. So I ask them, personal questions like, what does it smell like? And a lot of times they have no sense of smell. So you actually have to say, well, has anybody who's close to you ever complained about a smell? And not infrequently you'll say, yeah, my wife says I smell like a dying animal. Well, that's because they've got an anaerobic fungal infection. So try to get that history out of them. There's some data for oral steroids. I'll show one of the papers. We take people that have, say, with ARD or allergies, truly pan-sinusitis. You don't see a single drop of black of air on their CT scan, and give them 2 or 3 weeks of steroids, maybe with or without antibiotics, and get complete clearing of their mucosa. It's sort of a medical science procedure. So we do that for everybody. But if that clears them, then they probably don't have the biofilm issue. A little bit of data on Xolair for CRS, I'll show you that. And then the mainstay is surgery. Surgery is just unbelievably expensive and doesn't usually cure it. It's something that has to be done again and again. So again, just lots of money, lots of time, lots of effort, very little return. So it's a very open space, if you will, but nothing's really worked. So again, this is just one review from Cochrane, but there's pretty good data that somebody who's already had a FES, a functional endoscopic sinus surgery, that you can prevent, or you can at least delay the need for another surgery or make them feel reasonably good for a while, but there's no data that it actually clears CT scans, which is what you want to do to get people in a really good shape. Again, there's data from the trials that were done on ARD patients where they also did nasal questionnaires that you do help the nose as well. Not surprisingly, it's one airway, so if you're helping the lung, why wouldn't you help the nose? But even in there, we thought initially these would be designer drugs for the ARD patients because they've got these 5-lipoxygenase pathway issues. But it doesn't seem to work in any greater percentage of those patients than the patients who have run-of-the-mill allergies. So the combination of intranasal steroids and leukotriene modifier makes sense as well because they really can attack from different perspectives. And again, the data is pretty good. It does improve CT scan scores. It does improve symptoms. But a couple of issues. One was that the study that they didn't have any placebo controls. Didn't have either one of the two agents as a single active control. And it was a relatively short dose, and they used double the dose of cortisone. Maybe go back. So when you see somebody, particularly I think with chronic rhinosinusitis and nasal polyps, and that's really a distinction that is pretty important. They seem to have different underlying pathogeneses, but we try to increase the delivery of steroid to their upper airway. And one of the simplest ways to do it is just to double the dose of their intranasal steroid. I'm actually a huge fan of using a bit of Afrin first, because the people who have CRS may not have nasal polyps, may not have hypertrophy turbinates, and then they may not have just plain old nasal mucosal hypertrophy. So how well can your steroids get up in their nose? So I'm a huge fan of using some Afrin to get some better deposition of the intranasal steroid. So everybody frowns about that, and I can't tell you, every single patient who I suggest it to says the same words to me. They all say, but you're not supposed to use it for more than 3 days. It's unbelievable how every single one has either heard that or read that on the bottle. It's truly unbelievable. So I say to them, yes, I understand the bottle says do not use for more than 3 days, but there are words that precede that, and there are words that come after that you're not giving me. Give me those words, and nobody knows those. So what it says after that is without consulting your physician. I say, well, there we go, you just did. And they say, yeah, but what about what comes before that? Okay, so what comes before that is 2 or 3 sprays in each nostril twice a day. That's huge. That's just way too much, and that's what leads to the problems that say you shouldn't do it for more than 3 days without consulting your physician. So I just have patients do 1 spray in each nostril once a day, even if they're doing BID intranasal steroids, because it opens your nose for 10 to 12 hours. So if you do it before in the evening, you'll still have an open nose in the morning, or vice versa. So I have them do that, and it's really been pretty huge, and really haven't gotten into any trouble. And I think the reason is twofold. I think one is sort of physiologic, and then the other one is a very interesting one. So physiologically, I think the problem is that when you do 2 or 3 sprays in your nose, you so vasoconstrict the nasal mucosa that the brain says to itself, I've had this all wrong. Because when your nose is dilated, your nose is all stuffed up, I think the brain says to itself, we need to send vasoconstricting signals to try to open things up. But while your nose, while the vessels are dilated from allergies or AERD or infection or whatever, whatever the signal the brain is sending to vasoconstrict, you just can't do the job. So then you do 2 or 3 sprays of Afrin and you get overly vasoconstricted, basically overly decongested. So the brain, I think, says to itself, oh, I've had this all wrong. We don't need vasoconstricting signals. We're too constricted. We need vasodilating signals. So while your nose is under the effects of the Afrin, those brain vasodilating signals can't overcome it. But the moment that the Afrin wears off, your nose just rebounds from the brain's vasodilating signals. Now you can't stand that, so you go use more Afrin, and you wind up getting dependent on it. But if you do 1 spray, even twice a day, I think, but certainly once a day, you just get down to a nice normal vasoconstricted state, so that the brain can says to itself, I can worry about something else, and doesn't do anything. You can do that, I think, interminably without worrying about it. But if you are worried about that, what you can do is you can have them back it up with an intranasal steroid. So I have patients who have obstructive sleep apnea, who just have other nasal problems, but yet Afrin really works. Even some people with septal deviations, when they use some Afrin, get enough of a passageway that they're happy campers. So if you even have those patients do their Afrinites, some of them I just have them do it once a day and say, when is it more important for you to have your nose open during the day or during the night, and you can either use your Afrin in the morning or at night. But even again, twice a day, 1 spray, I think is actually okay if you back it up with nasal steroids. So for years, I had this idea that you could do that and in essence give you Advair for the nose. So it would be a combination of the oxymetazoline plus an intranasal steroid. So it's kind of like a LABA ICS, if you will, right? To the point that I actually pitched this to Sharing before Merck took them over, because they have Afrin. It's a Sharing product, and they have Nasonex, which is an INS. I said to them, make Afrinex, and you've got Advair for the nose. It'll be killer. But another one of my ideas that never went anywhere. But the thing is, for years I said that the beta, okay, so we don't put anybody, I hate to digress, but I always wind up digressing. We don't put anybody on Ventolin 4 times a day for asthma. Why? Because we know what happens to them that way is the same thing that happens if you do your Afrin. You wind up downregulating the beta receptor, you get less responsiveness and all of that. But if somebody hits the ER in status, you give them bronchodilator, but what do you also do? You give them a slug of steroids. And why do you do that? It's not going to work for 4 to 6 hours, but you're trying to upregulate the beta receptors and get that responsiveness back. So if you look at what a beta receptor is, you look at what an alpha receptor is, not surprisingly, they're incredibly similar. So I had the idea that if you use steroids with afrin, you would prevent the downregulation of the beta receptor. So sure enough, in 2012, somebody actually studied it. And this article in American Review of Respiratory Care Medicine, and they put a bunch of people on full dose afrin, 2 sprays BID, and then another group who had 2 sprays BID with an intranasal steroid, and nobody got rebound after a month doing it. And they had the same hypothesis that I did. So anyway, so I'm a big sort of afrin fan. Then I go to double dose intranasal steroids, and then when that doesn't work, I'll nebulize steroids, and then with Nasaneb or with the Neilmed bottle, and then if that doesn't work, even go to just putting budesonide directly into the nose, and that may work. Okay. So we're at Xolair. Again,
what do you think about, this has a lot to do with just the effectiveness of delivery of the steroid, the new dry products that are aerosol?
Yeah, so I don't know how much more actually winds up going into the sinus ostia. Nobody's really studied that. But I do think anything you can do to get it there obviously is going to make the difference, and that's why I kind of like the nebulizer. The difference, okay, so I think the difference is Ventolin inhaler, Q-nasal, versus a nebulized albuterol treatment or a nebulized budesonide for the nose, right? So number one, you could deliver a much bigger dose. That's what a nebulizer does. So a nebulizer dose of albuterol is 6 times the dose of the inhaler. And you get 10, 15 minutes to try to work this mist up into your nose as opposed to one shot. So I still kind of like it, and these patients tend to be very, very good about doing it. I still like the concept of a nebulizer to just get this flow going up after 10 or 15 minutes. So omalizumab, Xolair seemed to work in some patients, not surprisingly, because I think a lot of CRS patients do have allergies as their underlying disease. But again, much like intranasal steroids, much like most of anything else, symptoms are better, CT scans seem to get better, but nobody's disease really goes away. So not surprisingly, when there's nothing on the market that's approved by the FDA, then people try everything. So everybody's been into probiotics and herbal teas and vitamins and homeopathy. The more things that are out there that people have tried, it's just because nothing really works. But it's just unbelievable what's been tried. Surgery, which is you think would work, is very expensive. So averages maybe about $15,000 when you add up the surgeon, the anesthesia, the OR fees. But with that price, there's 250,000 procedures done in the U.S. every year. So that's the market that the venture capitalists are looking at and saying, that's what we're spending, and we can get a piece of that pie, it would be great. They say they've been discouraged over years. So in a Cochrane review from 2006, there were actually 3 randomized controlled trials of FES surgery for chronic sinusitis. And interestingly, compared to everything else that we do, they couldn't show that in the long term things were any better. And we all know that. Our patients have had one sinus surgery, have had many sinus surgeries. And I think really that only winds up leading to more biofilms along with all the antibiotics that they get pre and post-op.
Control those with sham procedures?
No, it was just, no, definitely not. No, because you can't really, I guess you could do a sham, no, they were not sham procedure controlled, which would be a really good idea, but usually you do a sham procedure controlled trial when it looks like the procedure works, and if they're doing it compared to not even doing surgery, why do you, and if it doesn't work, you don't really necessarily need the sham, you know what I'm saying? And the other problem is that you could do a sham, say somebody who has had arthroscopic surgery of their knee, because you could just put I guess you put something in there and not really do anything. I guess you'd have to put somebody in the OR and put them to sleep and do all of that and not do this. Anyway, it's never been done.
The control is not really an appropriate term.
Well, yeah, but it's a controlled study. It's just not a sham procedure controlled study. But if the surgery worked, or if it looked like it worked, then you want to go back and say maybe it was just because the person had surgery. Then you want to do a sham control. When it doesn't work, you don't necessarily need to do sham control. So the thing is that, so over the years, people are wondering, what is the problem here? And it looks like it may be the fact of these biofilms. So again, even after surgery, I think even more likely after surgery, you can wind up with these biofilms. So in this study, they looked at 24 patients who had failed medical management, then wound up and had surgery, and they found biofilms in most of the patients. Studies that look at the presence of biofilms are somewhat variable from study to study, but they're clearly at least 50% of the group. why is it not everybody, or why do you get the number from? We actually had an interesting discussion last night about the fact that it seems to be people have different levels of susceptibility to getting the biofilm presence, and it has to do with their innate immune response trying to fight these bacteria. And that turns out to be related to our taste receptors. So it turns out that the taste receptors are not just on our taste buds at the back of the tongue, but they sort of permeate the upper respiratory tract. At years, people wondered, okay, they're there, but what the heck do they do? And it turns out that at least some of those taste receptors are involved in innate immunity, and people who have much more powerful taste receptors have a more powerful innate immune response, and maybe the ones who get fewer biofilms. So that's kind of interesting. But in any case, you have all this mucosal inflammation, and whether it's type 1 inflammation from allergy, whether it's leukotriene-driven or 5-lipoxygenase-driven and aspirin sensitivity, whether you have cystic fibrosis, whether you've got, again, problems with your oxidative burst like these taste receptor patients have, whether you've been a smoker, whether you live in polluted areas, whatever it is, you have this intense mucosal inflammation. And that winds up doing a lot of things. It winds up decreasing mucociliary function, the more sort of crap that you have up in there. Every time you get a viral infection, you're denuding the respiratory epithelium. That you wind up getting these bacteria down there that become selected for species that are more likely to form biofilms. So when you look at all the different types of people that wind up with chronic rhinosinusitis, they're really different. Some people just go into it, they just had some nasal obstruction, they wind up having surgery, and before you know it, they're there. So if you look at all the different groups and what they have in common, and the one thing that really sticks out is the fact that they could have biofilms. So what a biofilm is really, so it's a complex aggregation of microorganisms. This is the official definition, but it really sums it up very well. A complex aggregation of microorganisms that are irreversibly associated to a surface, and then they excrete this protective adhesive matrix. So it's not that there's a particular species that does this. This is a community, a microscopically thin layer of a community of different bacteria that all bring something to the table, if you will, and wound up helping protect themselves against the outside world because they have tremendous genetic diversity, they have tremendous structural heterogeneity, they have a sense of quorum sensing within the community. I'll tell you about that in a second. And then, if that wasn't bad enough, they produce this extracellular polymeric substance, abbreviated EPS, that winds up becoming a housing for them, and that's why you can't get topical steroids or nasal washes or anything to get to them. So that really makes a lot of sense, that if you're dealing with that, there's really almost nothing you could do that I just described in terms of treatment for CRS that's going to do very much. So normally we think of bacteria as just being the things that are kind of floating around that wind up getting to some place and setting up an infection. So those are called planktonic bacteria. And again, these are single bacteria that are floating around in the bloodstream, in the respiratory tract, wherever, and they do their infecting. But in biofilms, they're called sessile bacteria. They're actually, again, working in community. They will, within this microscopic layer, send one species or one of their group up to the top to sense the outside world, and the rest are beneath it, metabolically inactive. So if they're metabolically inactive, you can't even give them an antibiotic to kill them. So what happens is the group that's up on the top at the moment is sensing what's coming down the pike, and if they get an antibiotic sense, it's going to kill probably most of them, maybe even all of them, but the ones that were metabolically inactive underneath are able to sense that, and either they become resistant to it or they just send a different group up to the top, a different infantry, to be the next group to take the hit. And they're just living in there, protecting each other and living as a community of different kinds of bacteria in a community. So it turns out, not surprisingly, Pseudomonas is notorious for that. So not only do we wind up selecting the Pseudomonas by the antibiotics we give, but we do it because they are particularly good at that. And staph are really good at that. And one of the two big organisms we see in sinuses when you culture is Pseudomonas and staph. It doesn't really even matter if you do something to kill them because you still have these metabolically inactive species underneath.
If you look at the mucus from cystic patients, is it consistent with the same stuff that you see in these biofilms?
Yeah, so cystics are the big, always known biofilm producers. But biofilms are everywhere. So our teeth, our dental cavities and dental plaque are biofilm. Infected catheters sitting in vessels are biofilms. And they are literally everywhere all the time. And that's why it should be surprising to think that they're going to be in people's sinuses. But even before people sort of sense that they can be everywhere and perfectly otherwise healthy people, it was very well understood that this is what cystics get into trouble with, absolutely. All right. Yeah, and besides bacteria, fungi can make biofilms as well. I think some of the data when people were thinking about allergic fungal sinusitis or just fungal sinusitis, it really wasn't so much active infection or whatever, not even necessarily allergic, really it's maybe a biofilm issue. So again, they're protected by their housing, by this EPS, this extracellular polymeric substance. They're protected from extremes in temperature, from pH, from UV light, from moisture changes. You can't get your immune system in there, so you can't phagocytose them. They can concentrate whatever nutrients come in and keep it for a later date, if you will. Again, they have the cell-to-cell signaling pathways that are called quorum sensing, which allows them to sense what the antibiotic is and actually exchange genetic material so that one species becomes antibiotic resistance. So again, they're on heart valves, on plastic catheters, really anywhere because they can clean to surfaces. So what happens is, the bacteria is sort of floating along, and it's kind of like, the eosinophils in the blood vessels. They will adhere to the surface, and then they will aggregate, and then they grow, and then this little mound will separate, and they fly away. So when you look microscopically, you can actually do this with either electron microscopy or even better, something called confocal scanning laser microscopy. When you look at the sinus, you don't even see a complete layer of biofilm. It's actually in patches. So they're just like all over the place. So they keep detaching and spreading, and growing. So this EPS is truly amazing. So it has protein in it, has polysaccharides, but as the bacteria die, they recycle their DNA, other parts of their cells. They build it out of that. They build it out of liquids. They also build it out of what are called humic, H-U-M-I-C, humic substances, and that basically just means decaying organic matter. So you think about all the inflammation in the sinuses, how you're denuding the respiratory epithelium, they'll recycle that humic material, if you will, into this extracellular polymorphic substance that provides the housing, the protection, the barrier for them to actually be killed. So it's estimated that this EPS can account for anywhere from 50 to 90% of the total organic material in the biofilm, because again, other than that, it's just the actual bacteria, and they don't really have a lot of mass. So that's really the problem. Is how you. So I think if we can get to break up EPS, and it doesn't even matter, you don't even need an antibiotic, because now you have these naked bacteria, and then you can kill them with almost anything, or you just get them to wash away. So I think that's their Achilles heel. So obviously, this really gives these bacteria a huge advantage in the environment. You can, whether the environment is hypoxic, hypoglycemic, no matter what's going on, doesn't really matter, because the ones that are quiescent are metabolically inactive. It doesn't matter to them. They also have this, again, quarantine sensibility, and that leads to the antibiotic resistance. And again, they've got the safe housing to live in. So the last bullet point says that it's been estimated that this EPS actually makes the biofilms anywhere from 100 times to 1,000 times more resistant to antibiotics, because you just can't really get them where they need to go. So this is really too busy to go over in detail, but it just goes through a number of studies in the literature that were looking for the presence of biofilms in patients with CRS. And there are some adult studies, some children's studies, some post-surgical studies, but sort of the bottom line is that most of the patients had a biofilm. And again, oftentimes what you wind up culturing is Pseudomonas and staph as a big contributor, and those are hard to deal with in an antibiotic sense anyway. So people have been thinking for a long time, what can we do about treating these? So what's out there now are, what people are talking about out there now is actually doing low-level ultrasound of the sinuses. I'll show you a little bit about that. Something that's called antimicrobial photodynamic therapy, where you actually try to get a better oxidative burst. And then the space, if you will, that I've been dealing with is in the pharmaceutical, nutraceutical area with things like honey. I'll tell you why, xylitol, myrrh. I don't know if you know what these things are. We'll get into that. And then detergents to try to break up biofilm. So be interested, a different talk, if you will. Okay, so ultrasound. This is, again, low-frequency ultrasound. It sounds very, very sort of weird to me. You're just putting this ultrasound, the transducer, over the maxillary sinuses. You do that for 2 or 3 days a week for 6 sessions. So this one study had 22 subjects, 2 dropped out. So they had data on 18 improved, whatever exactly that means, and 2 got worse. So the improvement was symptom scores, the SNOT 20, and it improved by 34%. But not a controlled study, as Leonard was saying, certainly not a sham study. This just begs to do a sham study, because everybody obviously even knew they were getting it. But it's just sort of enticing. Maybe it'll do something. I'm not sure whether it's necessarily working on biofilms. Maybe the ultrasonic wave would do that. I wonder about getting a device maybe that could go into the sinus rather than a device that goes over the sinus, but I'm not a biomedical engineer, but I think that may be a better way to go. So this device already has a trademark name called Sinuwave. This is great, the Sinuwave Photodisinfectant System. Really a brilliant idea. So they take very low concentrations of methylene blue and EDTA, and that winds up sensitizing the surface if you get it light activated. So you add a very low frequency laser light, totally painless laser light, it activates the methylene blue, and then it winds up doing something that increases your oxidative burst, and you get all these free radicals released, and then hopefully that will kill the bacteria. Again, a good idea. I don't know that it will do anything to that EPS, the polymeric substance, but it's pretty interesting. So this is actually available in Canada. Okay. So what they claim is, this is directly from the company's website. So what they claim is, in just a few minutes, this will destroy multi-drug resistant species of biofilms present on the sinus mucosa. And what do they mean by that? Well, what they mean by that is 2 things. In vitro, if you take one of these planktonic species, again, Pseudomonas or staph, and hit it with this activated light thing, yeah, it kills them. But I have a problem with that because, again, in working in this space, what you have in a test tube lacks the EPS because it's just the bacteria floating in the test tube. You know that they're planktonic, meaning potentially biofilm producers, because they don't float around in the test tube. They're all stuck together. So that's the in vitro model for a biofilm. But without the EPS, to me, it's so unlike the human model that showing you can kill it in a test tube doesn't mean an awful lot. But anyway, and obviously, it'll kill drug-resistant organisms. So it doesn't care what the organism is. They're all going to be sensitive to the free radicals. Anyway, so they talk about it effectively eliminating all these planktonic forms of organisms. But again, not surprisingly, they do have some studies in, again, animal models. They'll do sheep models. Sheep have pretty good-sized sinuses. So they'll infect them and deal with them. But it's in vivo, but it's still not quite the human system is. It's still a model. It's not the naturally occurring biofilm with a lot of EPS. They claim that it significantly depresses the local inflammatory response, and that doesn't sound good, but in a sense it is, because you're giving steroids to do the same thing. So number one, it doesn't increase the inflammation, because that might be irritating. It actually decreases it. Obviously enhances neutrophil activation, because that's what it does. It's stimulating this oxidative burst. Vasoconstricts the tissue, so you get a little bit of immediate sense of relief, but you can use Afrin for that. What's really weird is, and I haven't actually seen the data because this is directly from their website, produces longer term, up to 6 months suppression of circulating acute phase reactants like CRP. So, I've never seen a study that suggested that ESRs or CRPs were elevated in chronic sinusitis anyway. We all have those patients in our practice, and people get these ESRs and CRPs measured all the time. You'd think we would know if that was there. So I was explaining to patients that you don't really have a systemic immune response to your sinusitis because it's like an abscess and the body could sort of care less about it. That's part of the reason why we can't effectively treat them. But that's their data. And then the main thing is that it's safe, and the safety study is actually out there. So this is actually commercially available in Canada. But there's one abstract that was presented about a year and a half ago at an American Rhinologic Society meeting, which is the ENT's academic organization. So they present very good academic work at their meetings. So they had 9 CRS patients that got 29 individualized sinuses treated, right? Because you have to do multiple sinuses. And the good news was that the short-term safety data looked good. And then this is just an abstract, they talked about several patients showed complete clearing of their sinuses, but how many several is out of 29? Again, no control and all that sort of thing. But it's out there, and I'm sure they're doing additional studies.
That's a device that gets put in the sinus.
Yes, exactly. So this is an ENT done procedure in the office. They actually put this device in. They have different ports on it. One port delivers the EDTA, methylene blue solution, and then the other light activates it. Yeah, but it's pretty interesting. Yeah. So then I came across Manuka honey. So this is sort of interesting that hydrogen peroxide, which would kill anything, is actually a component of honey. It may be one of the reasons why it's good when you have a cold. Your grandmother would give you some honey and tea. Anyway, it has hydrogen peroxide, which is pretty good. But what's unique about Manuka honey, if you will, is that it has something called methyl glyoxal. And that is actually a very powerful antibacterial molecule. And it's really in very high concentration in the nectar of these Manuka flowers. So it's thought that Manuka honey will have a more powerful anti-inflammatory, more powerful antimicrobial effect than regular honey, if you will, just made from the pollen of other plants. And it turns out that these days there's everything. There are sort of fake Manuka honeys out there. So if you want to get into this, you have to look for the unique Manuka factor, the UMF. And you want that to at least be 10. So what that means is that this glyoxal factor is 10 times higher than other honeys would be. So the work that's been done has been with the oral ingestion of it. And that makes a lot of sense because I don't know how you're going to sort of stick honey into your sinuses. That may not be a good thing, or I don't know how you get it in there. But that's the theory. That's how people have been using it. There aren't really good controlled studies with it, but it's just something that's out there. And I'll try to bring it back to something that might be more interesting when I wrap up. I've been really interested in xylitol for a number of years. I actually didn't realize that the cystics were doing this until after I got into it. So xylitol is really interesting. So it's a natural sugar that has equal potency to sucrose. And what it's mostly used in are in the diabetic products that are quote-unquote sugar-free. Because even though it does have calories, it has maybe a third of the calories of sugar, but it has a very low glycemic index, so you can't really use the calories for energy. So it's very sweet, but basically low to non-caloric. So if you buy sugarless gum, it'll have xylitol or one of the other very common 5-carbon sugars. So you may have heard of maltolol or sorbitol, and then there's xylitol. So there are all these 5-carbon sugars. So it has literally no known toxicity at any concentration. So it has an FDA GRAS rating, which is generally recognized as safe. So you can just use it in anything you want to use it in. You don't have to get their approval. So this is this great theory. So a 5-carbon sugar will be taken up by cells as readily as a 6-carbon sugar, but it won't go through the Krebs cycle. And if you don't go through the Krebs cycle, you can't generate any energy. So the theory is if you get it into somebody's sinuses or cystic fibrosis, if they inhale it as a nebulizer, and you can flood the area with that as the main sugar, then the bacteria will not be able to grow as well, maybe even die off because they can't make any energy. So it, in fact, has been shown to inhibit the growth of strep pneumo and the attachment of H. flu to human nasopharyngeal cells in vitro. So that's something that's quite interesting as well. Not been used. So the studies of it being used in sinusitis are not great. It doesn't necessarily work better than a placebo. But again, I think the problem there is how you're going to get it through that EPS in a biofilm. So if you can get it in there, I think that might be very helpful.
There's a product called X-Clear, isn't that xylitol and a nasal spray?
Yeah, exactly. Yeah, but again, I don't know if that's going to get into a sinus at all. But again, if it hits that EPS, or again, if there's a mucus layer above the biofilm layer, it can just get all attached to that. So I actually had a number of my patients use xylitol in a sinus nebulizer. And again, totally anecdotal. I never really presented it or anything, but it was definitely a very distinct group who had fewer sinus infections. And I knew that because I could just count the number of times I had to do antibiotics for them. But it wasn't, to me, it wasn't sort of helpful in a broad enough number of people that I felt it was worth pursuing alone. And that was even before I realized about the biofilm issue. Now I know why. I think I know why it wasn't as effective. So I'm not sure that Excludor will do all that much, but it won't hurt. That's the other thing. It's just really nice. So then we can go back to antiquity for myrrh, like frankincense and myrrh. And this has been known again since antiquity as having an anti-inflammatory effect and also a bit of an antimicrobial effect, and also seems to be totally safe. If anything, it's soothing. And it's just comes from the sap of a plant, and you can really buy this in health food stores. When I found out about this, I had my patients who were using the xylitol nebulizer stuff add the myrrh to it. I couldn't tell that it really did anything, but it's just an interesting thing to add. But I think the more the merrier.
What's a common name for that treatment?
It's myrrh, and you can actually buy it in health food stores as oil of myrrh. It's pure. It just what I would have patients do is just take a drop or two of it into their Nilmed bottle pint or the nebulizer pint, and then they would put in a teaspoon of the xylitol. But this was the big breakthrough. So this was an interesting story, and I've got some time to tell stories. So you can tell I was thinking a lot about what to do about this condition. And the more when I learned about biofilms, when I heard about the EPS, I said, how could you break up an EPS? And I said, what you really need is you need a surfactant, right? The surfactants do that sort of thing. So a surfactant is a shampoo that you used this morning when you washed your hair, if you did. It takes grease, all the dirt and grease in your hair, and basically emulsifies it as a detergent. That's what soap is. It's just, they're really surfactants. So I spent a lot of time thinking, you can't put soap into people's sinuses. So I said to myself, wait a second. Johnson & Johnson baby shampoo, you can get it into babies' eyes and it doesn't burn, and that's a surfactant. Why don't we put that into the sinus nebulizer along with the xylitol, along with the myrrh? So I didn't know this, but back on the East Coast, Alex Chu, who was University of Pennsylvania at the time, had the same idea. But, he's an academician. I'm just practicing medicine and will continue practicing medicine. I was having my patients do it. He actually decided that he wanted to look into it. So he was taking it apart molecularly and trying to figure out what the active substance is, but in the meantime was having patients use it. So my patients had some problems with it because it would bubble out of their nose, so adherence wasn't great. And some people felt that it was a little bit irritating, so you had to keep getting the concentration down. He found that 1% Johnson & Johnson baby shampoo was not at least irritating to the patients and didn't seem to bubble as much as my concoction. But what he did find was, we'll talk about it. Okay, so he wound up, this is Alex Chu, the first author of this paper, again in the American Journal of Rhinology, because that's the journal that comes out of this American Rhinologic Society. So it's a very academic ENT journal. He used baby shampoo after fest surgery. So he had done some in vitro testing showing that it had truly disrupted the biofilm. Again, it's in vitro, so it doesn't have as much of the EPS, but at least in vitro it seemed to do that. So that was his sort of preclinical study to decide that he should go this way. So it was 1% baby shampoo dissolved in normal saline seemed to be the ultimate concentration for inhibiting in vitro Pseudomonas biofilms and also not irritating to the patients. Took 18 patients who had an average of almost 3 surgeries each, and after their last one had them do this. So 2 of the patients, 2 of the 18, had to stop it because they found that it was irritating. But 46.6% of the patients, almost half of the patients, had clinical improvements in their subjective symptoms, and 60% of the patients specifically said that they had less of the thick postnasal drainage. So they decided that this seems to be a pretty inexpensive, tolerable way to help people post-surgery, and it would be a particular benefit in getting rid of that thick nasal discharge. So that sounds pretty good, but this was in 2008. The story continues. You need the rest of the story. So in studies that were done subsequent to that, this is now 2011, they took patients and looked at mucociliary clearance time, because that would be one if you want to see whether or not there could be an adverse effect on the cilia with this shampoo. And they actually found that mucociliary clearance time improved after patients used the shampoo. So that sounded really good. But this was a very short study, and it was a very short-term exposure. So although it looked good and made people, by this point already, 2011, I'm sure some of the people in the room were starting to use baby shampoo in their CRS patients because the word was kind of getting out. But there's more to come. So now Alexander Chu started to look at the actual surfactant. Okay, we're not there yet. So let me see what this one is. Yes, he was doing some mouse experiments trying to get the actual individual surfactant to play rather than having to use shampoo. And he felt that, again, in this mouse model, when he isolated the specific surfactant that was active, it seemed to be safe to cilia. Yeah. So he was, so rather than using the baby shampoo, because, okay, going back up, he didn't publish the fact that the baby shampoo itself was toxic to the cilia in this mouse model. So he knew that that couldn't be commercially viable. But when you think about Johnson & Johnson baby shampoo, how much of it is actually the surfactant? You've got color, you have fragrance, you have preservatives, and he thought, logically, that it was one or more of those ingredients that was killing the cilia in the mice. It couldn't be the surfactant. So he, splayed the shampoo out on columns, activated the actual surfactant, tested it in the mice, and it wasn't toxic to cilia. So he was studying that, and it turned out that NeilMed got wind of this and literally just bought the compound from him. And they made it into a product called Sinusurf. So I don't know whether anybody has heard of Sinusurf, but the most brilliant name I could think of, right? Sinus surfactant. So it was Sinusurf. It was marketed. You could get it online anywhere. I can't tell you how many patients were using it, but it was voluntarily withdrawn from the market by NeilMed in October of 2011. The reason is a little bit fishy, but it doesn't really matter. It's gone. There were a lot of reports of anosmia following its use. Now, there's a lot of reports of anosmia anyway. You get a virus, you get anosmia. People get surgery, they get anosmia. And there's a lot of complicating anosmias out there. And whether this was, real or not, I don't know. But it was enough of a signal that the FDA started to get wind of this that, again, rather than pursuing NeilMed on a claim of anosmia for the product, NeilMed decided to just withdraw it. So Sinusurf, which I thought was going to be this incredible thing for biofilms, is now not even available. So I went back sulking and thinking and trying to figure out what the heck can I do for my patients. So I had a chance meeting. They talk about spending your life trying to do something and plodding along, but there has to be something serendipitous and something accidental to happen. So listen to this. So I'm also the chair of the IRB at the minute. So every year I give a human subjects update for the group. So I'm giving my grand rounds at the main auditorium. I walk out of my talk, going down one of the hallways, and approaching me is a guy that I sort of recognized or thought I recognized, but it took me a while to figure out who it was. And he sort of thought he recognized me, but we actually passed each other, and then like a Western duel turned around. And I said, Charlie Cochran? And he said, Ron Simon? And he said, what are you doing here? So I said, I just gave a talk for Grand Rounds. And I said, what are you doing here? I'm going to see my dermatologist for my annual exam. I said, oh, really? He said, what was your talk on? I said, well, I was talking about randomized clinical trials. And he said, oh, I need to know about that. So he's a retired professor at the research institute. What do you need to know about that? Well, I invented this molecule. This drug company bought it. Now they want to look at it for the purpose that it was designed for. I said, really? What is the molecule? He said, it's an analog to human surfactant. So I almost fell on the floor. And how could that be anything but safe? It's a surfactant. So sure enough, there's a product out there called Surfaxid, which is, again, an analog to human surfactant to be used for infants who have respiratory distress syndrome, right? They need surfactant to be able to open up their lungs. There are animal surfactants out there, but the problem is they are going to be immunogenic. They don't actually work quite as well as this one does anyway, but we couldn't use it in our trials if it was an animal product. Imagine putting animal protein into allergic sinuses. So he just designed this incredibly brilliant molecule. So you need phospholipids to be a surfactant, but the preemies don't have the protein. They're lacking the protein. So he designed something called the KL4 protein. So it has this protein 2 phospholipids, and then a preservative. So all it is are 4 lysines and a leucine, 4 lysines and a leucine, and that's it. Sorry, lysine and 4 leucines, a lysine and 4 leucines. So lysine, for some reason, in scientific jargon is abbreviated K, and leucine is abbreviated L. They need something else for the lysine, because the leucine had an L, so I think they used the letter that was next to it. So anyway, so it became KL4, lysine, 4 leucines, and at the other end of the molecule, it ends in a lysine. So 2 lysines on the end and the leucines in the middle. So that was his molecule. It's 21 amino acids. It's totally non-immunogenic. But it disperses biofilms, it's mucolytic, it's antimicrobial, and enhances mucociliary clearance. This is like a dream to me. So,
Hope this ends well.
yeah, so Discovery Labs is a pretty, if I must say, probably a pretty poorly run company, and they're constantly in financial trouble. They're not making nearly the money that they thought they were going to make on surfactant, because it's just as expensive as the animal one, and there's no incentive for a hospital that's just giving it one time to the preemies to go for the human one, because the animal ones have been working. So they have some other products in their pipeline that are going to be better. But Charlie and I are trying to engage them in going for another FDA application. And they seem now to finally have some interest. But because they only used it once in the preemies, and we want to use it multiple times, this is really almost going to be starting from the ground up again, because we'll probably have to do preclinical studies in animals to show that it's not harmful. We're going to use it multiple times. It's going to be a while, but hopefully there'll be something happening. So this would be pretty cool, I think. It's very expensive, as you could imagine, but when you think about the fact that this could be the only FDA-approved treatment, from a pharmaceutical company's perspective, that's really good, obviously, for marketing. So you could just go use it right away. I think much more likely, especially with insurance companies, they would say you would have had to have a failure of whatever the non-FDA-approved standard medical management is, or maybe even you had to have at least 1 surgery and then had a relapse. But all of that still, for a pharmaceutical company, is huge bucks. This is, I mentioned before, $6 billion a year is spent on the product. So when you look at it compared to Xolair or compared to sinus surgeries, I think that it could be a cost-effective treatment. But when I thought about it further, so the preemies need the protein, but we don't need the protein. There actually are elevated levels of surfactant protein in the sinuses because it's inflammatory. The body's trying to make that. So we don't really need the protein. We just need the surfactant, if you will, the phospholipids. So another idea that I have is to literally make a unique concoction of all the things that I mentioned to you before, and take that methyl glyoxal from the Manuka honey, and instead of using the honey part of it, because I don't know about putting honey into sinuses, add something with the xylitol, a little bit of myrrh for the anti-inflammatory effects, and then the phospholipids to break up the biofilm. So I'm hoping that maybe we can turn this into something in the space that venture capitalists don't want to go to really help out people's sinuses. So thanks.
You didn't talk about using either pomazyme or N-acetylcysteine in any of your discussion. Do they not work on these biofilms?
Yeah, so those are DNases, like, again, cystics will use. So the problem is, so there's a little bit of data that in vitro they will break up these biofilms, and I said it's just a bad model. There's so little DNA, or there could be so little DNA in EPS, that I'm just not real optimistic about that. It's such a specifically targeted thing. I want a more generic surfactant to break up the EPS, but there is a little bit of data that it helps, and I think people are pursuing that. The other thing I remember, from the days is how incredibly irritating it is, and like asthmatics couldn't use it because it would just produce incredible bronchospasm. So it's kind of hard for me to believe that it's going to be something the sinuses are going to be happy to accept. But there are people who are looking at that. That's a good point. Can you talk about your approach? So you have a new patient comes in, chronic rhinosinusitis. Like, what's your first best progress?
Yeah, so you want to find out what the driving is. Is it ARD? Is it LPR can drive it? Cystic fibrosis can drive it. Immune deficiency can drive it. But once you have the driver, I think the biggest problem is when it turns out to be eosinophilic, because the other conditions we have treatments for. So it's eosinophilic ones, whether it's allergy or ARD, they're the biggest problems. So again, if they've got pansinusitis, we give them 2 or 3 weeks of prednisone, much like we do for an asthma exacerbation, usually along with antibiotics, even though, again, there may not be any air fluid levels, but you just wonder when they're so totally impacted if there's probably bacteria in there. I like, augmentin, generic augmentin for that. It covers most of the bases. Again, an anaerobic one if they have any of that sensation of that horrible smell I was talking about. And then I get a repeat CT, and most of the time it's clear. And then it becomes, how do you maintain that state? And then it's the issue of, again, topical steroids. For the CRS patients, a lot of times then they're done, because then you know what their underlying disease is, you could treat their disease. It's really the ones that have polyps that are a problem, because they'll grow back. And that's when I go through that escalating topical steroid. Oh, I forgot. So the first thing I do is double the dose of intranasal steroids, and that's really easy to do these days because they're generic. When that doesn't work, if I go not so much to Q-nasal, but I go to Flovent. And the reason is, so fluticasone, Flonase is 55 micrograms of fluticasone per spray. So if you do 2 sprays, you have 110. You do 2 sprays twice a day, you have 110 BID. You can get Flovent 220 and do 1 spray, and now you doubled it, right? You went from 110 to 220 with 1 spray of Flovent. Do that BID, that got 440 going in the nose with a spray that's at least as powerful as a nasal spray. So I've had any number of patients whose polyps didn't come back with that. Maybe it was the propellant that killed the polyps, but whatever it was, it doesn't come back with that. That's my next step, and then it's to the nebulizer, and then it's to just the drops of budesonide right in the nose. The patient lies on their back.
How do you get the Flovent into the nose?
Okay, so what I do is I have the patient buy a rubber baby bottle nipple, and that goes over the mouthpiece, and if you clip the end of it, it's just a perfect nasal adapter.
Do you really need to do that? I mean, most people's orifice of their nostrils big enough that they just hold it up to your nose.
Yeah, I'm worried it's going to go in the eye, because when you look at the ophthalmologic literature, there's an incidence of glaucoma and cataracts on people on intranasal steroids. And it's hard to imagine how that happens, but the 2 ways that I can think of it happening is if somehow it goes retrograde through the nasal lacrimal duct, and maybe something like, a Flovent or a Q-nasal could be more likely to do that because it's very powerful, or that this person is spraying it in their eye, inadvertently, and I worry about that because if they don't line it up quite right and get it totally in their nose, some of the vacuum could be just floating around their eyes. It's just so easy to get the rubber nipple, and it's so comfortable for the nose, you don't have to worry about trying to get it in there. It just pops right in there. It's very convenient.
This is not science, this is anecdote, but I always worry just how much is wasted in the delivery process through the rubber nipple.
So, they're literally cutting off that other end. So, I think, some of it may sort of Venturi principle and go in there. Yeah. None of this is perfect, but I kind of like what you're saying.
She tried to trick me. Sorry,
You can't leave early.
I like what you're saying, but I just worry about right.
The way I have people use, this is just anecdote because none of these things are approved, but the way I have people use budesonide in their nose is put it in a squirt bottle last week and just deliver like 1 milligram a day or so, 2 bottles a day. Last week, the surgeon basically said, put it in a large meal med and do it in a big volume.
I don't like that idea because I think most of it winds up swallowed. And it's not dangerous to swallow it, but I just want to get it up into their nose. So I like what you're saying, but it's a lot of volume to be delivering, so you're still going to get stuff running down the back of their throat. That's why I like the nebulizer, because the nebulizer delivers, like Sinuneb device, say, for example, delivers the medicine in about 5 minutes, but it's this incredibly fine mist, and the patients don't wind up all stuff in the back of their throat.
Do you have them diluted in saline?
No, they literally take the budesonide ampule, put it in, and they deliver it to one side, and they do another ampule and deliver it to the other side. Because the nice thing is, when you're prescribing it for asthma, and the dose is 1 BID, so they just do 1 on each side QD, and then they get the same effect.
Any other queries here? We'll have to have you back when this is a commercial product. Tell us about the controlled studies.
Simon's not busted.
I like that. Simon Snotbuster.
Get credit for that. Keep him out with the product.
Thanks again for coming. It's always a treat.
One guy.
No, not boring at all.
When I sit too long, I start talking.
Except I took the honey that name on steroids when I was in